Assalamu alaikum. I am Dr. Sumaira Bhatt. It is my great honor and privilege as a chair to welcome you all to the 19th annual Shaukat Khanum Cancer Symposium being held in collaboration with American Society of Clinical Oncology. We are grateful to ASCO for this collaboration and support in providing world-class speakers for this year's symposium. My special appreciation to Sarah Backman, the Administrator for International Outreach for ASCO, for all the time and patience. Thank you so much, Sarah. As we all know, COVID-19 pandemic placed new challenges on our ability to convene and collaborate. However, as an institution that places high value on education and research, our leadership decided to forge ahead and hold the symposium virtually. This year, we have more than 3,000 registered participants joining from all over the world, 82 international speakers, 37 scientific sessions, 146 talks, 52 oral papers, and 146 accepted posters being presented at the symposium. A big thanks to all the invited national and international speakers who have joined us live despite the time zone differences. I believe this symposium will provide a great opportunity to all healthcare professionals to broaden their knowledge and share their valuable experience. Through our presentations and conversations, we will unpack emerging trends and crucial issues related to the diagnosis and treatment of cancer. This symposium would not have been possible without the input of different dynamic teams at our institution. A special thanks to our supportive and encouraging management, our brilliant IT department, especially Ms. Sana Kamar for developing a user-friendly symposium website, which was a completely new experience for us, Mr. Hasib Ahmed and his team for providing us with consistent IT support, and our scientific committee has worked tirelessly to prepare a comprehensive educational program. And thanks are due for their time and effort. No doubt, our organizing and ensuring a flawless program is nothing short of an Herculean task. I would also like to recognize the endeavors of Symposium Secretariat, especially Ms. Anika Aga, and consistent support of my co-chair, Dr. Muhammad Asad Pervez. Thank you for all the hard work and dedication. Towards the end, I would like to thank the organizing committee, especially our Chief Medical Officer, Dr. Muhammad Asim Yusuf, and our Medical Director, Dr. Asif Loya, for giving us an opportunity and having faith in us to conduct this virtual symposium. I hope that this virtual meeting will prove useful in your professional enterprise, and I once again welcome you to the symposium. Hopefully, in these trying times, we will all think positive but test negative. With this message, I invite Dr. Muhammad Asim Yusuf, our Chief Medical Officer and an acting Chief Executive Officer, consultant gastroenterologist, to share a few words about Shaukat Khanum Memorial Trust Hospital. Thank you so much.
Assalamu alaikum. Good morning, good day, good evening, wherever you're joining from. We're delighted to have you all here with us today. Many of you will have heard a version of this talk before, but we recognize that there are always new members and new attendees of this session. And so we like to give a little overview of the Shaukat Khanum Memorial Trust, what we stand for, what our history is, and how the hospitals have developed. We're especially proud this year to have completed 25 years of clinical operations here in Lahore at the end of last year, just following the last symposium. So this is the main hospital in Lahore, which opened in December 1994. And superimposed on that is our second hospital, which opened in Peshawar, further north, towards the north of the country, in December 2015. The inspiration for the hospital, as many of you will know, is from the mother of Imran Khan, who was the captain of our national cricket team and whose name was Shaukat Khanum. Mrs. Shaukat Khanum succumbed of colon cancer in the late 80s, and her disease course and the journey that Imran undertook with her during her diagnosis and treatment was one of the main inspirations for him building the hospital. The other, of course, was the fact that he saw hundreds, perhaps thousands of poor patients in the cancer hospitals and in the general hospitals in Pakistan who could not either get a diagnosis or who could not afford treatment. And it was really their need that inspired him to try and build a hospital that would cater to the masses in Pakistan. This is our mission statement. I'm just going to highlight the bits in red that we think are the crucial or the core elements of the mission statement. We aim to act as a model institution to show that it is possible to achieve excellence in Pakistan. We're a cancer hospital dedicated to providing both curative and palliative therapy for cancer. And most importantly, irrespective of the patient's ability to pay. Once a patient is accepted into the system, it matters not whether they can pay for their care or someone else is going to pay for it. They will all get the same treatment and the best possible treatment available. We also have a role in education of both healthcare professionals and the public. And finally, we are a research center and we perform research into the causes and treatment of cancer. Pakistan currently has a population of, well, over 210 million now, with a very low public sector spending on health of only $6.4 per capita. There are approximately 170,000 new cancer cases a year, and because of the advanced stage at which these patients tend to present, between 60 and 120,000 of these succumb to their disease within the year of diagnosis. Our current projects include the hospital in Lahore, which is over here to the east of the country, the second hospital here in Peshawar in the northwest, and we have just started construction in September of our third and the largest cancer hospital in the country, in Karachi in the south. In addition, we have a number of diagnostic centers, walk-in clinics where patients with cancer can be accepted for treatment. And we also run a nationwide laboratory collection center network, which provides pathology testing facilities on payment to anyone who wishes them or needs them. Proceeds from these services are plowed back into the system to help treat more cancer patients. So the top two images you've already seen, the hospital in Lahore on the left and the hospital in Peshawar on the right. And this is the architect's rendering on the bottom of this panel of the hospital in Karachi, which is the biggest cancer hospital in Pakistan, the biggest Shaukat Khanum, and about twice the size of the hospital in Lahore. Our core values are quality and equality. Quality we've already spoken about, and we aim to aspire to the highest standards of quality possible. But most importantly, we provide equal treatment for all our patients, whether this be access, the clinical facilities, diagnostics, drugs, treatments, etc., or the hotel facilities. All our rooms are for 2 patients, and it's common to have both a paying patient and a supported patient in one room next to one another. Over 75% of all patients are provided treatment completely free of charge. And in the past 25 years in Lahore, and now for the past 5 years in Peshawar also, we've spent close to $470 million in providing free treatment to cancer patients who could not otherwise afford to pay. In terms of clinical activity, the various parameters that we look at to measure clinical activity are shown here. We've registered over 180,000 new cancer patients to the end of 2019. Over 2.5 million outpatient visits, 130,000 surgical procedures, over 500,000, nearly 600,000 chemotherapy sessions, and close to 1 million radiotherapy sessions. A part of our mission statement referred to the fact that we provide the best possible care to our patients, irrespective of their ability to pay. And the clinical services that we provide are obviously centered around oncology, so medical oncology, pediatric oncology, radiation oncology, and surgical oncology. And then we have anesthesia, internal medicine, pathology, radiology, nuclear medicine, and medical physics. We have the largest collection of, or grouping of oncologists in the country. We have 10 consultant medical oncologists, 9 surgical oncologists, 8 clinical and radiation oncologists, and 4 consultant pediatric oncologists. And the top cancers that we see in females are breast, oral cavity, esophagus, cervix, and ovary, in that order. In men, it's lung cancer or bronchial cancer, oral cavity, larynx, bladder, and prostate. While in children, it tends to be acute lymphoblastic leukemia, Hodgkin's and non-Hodgkin's lymphoma, osteosarcoma, and retinoblastoma. We also talked about the application of modern methods of curative and palliative therapy when we looked at our mission statement. And we do invest heavily in state-of-the-art medical equipment. We feel this is important to be able to provide the best possible treatment to our patients, but also because we need to provide our consultants and our staff with the tools they need to be able to provide the best possible treatment and to utilize fully their training. Most of them are trained overseas to a high level, and we need to provide them with an environment where they can practice their skills and provide the best possible treatment to all our patients. In Peshawar, we have just, we are about to commence surgical oncology services, which is the completion of phase 3 there. So that will add to our 8 fully equipped operating rooms here in Lahore. We have a number of diagnostic equipment, MRI scanners, CT scanners, PET CTs, and so forth. We have a state-of-the-art hospital management information system. We have a completely electronic paperless record, which is uniform across all our sites. So Lahore, Peshawar, Karachi, all our collection centers, they all use the same hospital information system. This was developed in-house and has since been donated free of charge to a number of government sector hospitals to try and improve the standards of healthcare throughout the hospital. We participate in a number of continuous quality improvement programs, the pinnacle of which for Lahore was in April 2018, when the Shaukat Khanum Hospital in Lahore became only the 3rd hospital in Pakistan and the first charitable institution to be accredited by the Joint Commission International. Our colleagues in Peshawar achieved the same accolade just over a year later. So in July 2019, they became the 4th hospital in Pakistan to be JCI accredited. And we're proud of the fact that 2 of the 4 hospitals so accredited are from the Shaukat Khanum Memorial Trust. We also have a number of other certifications, including HACCP certification for our food services, ISO for a number of our departments, and we also participate in CAP quality assurance programs, the College of American Pathology. Again, we were very happy early this year to be accredited by the American Society of Health System Pharmacists, which is the only body which accredits pharmacy residency programs in the United States. And Shaukat Khanum is one of only 2 non-US programs accredited by the ASHP in this way throughout the world. I think I've talked about some of these continuous quality improvement programs before. We also have a role in education of healthcare professionals, as I mentioned earlier. All our junior doctors are enrolled in postgraduate training programs. And obviously, these tend to mirror the sorts of specialties that we have: medical oncology, radiation oncology, surgical oncology, and so on, as well as a number of the internal medicine subspecialties that we have and that are important in the management of cancer patients. Education is not restricted to physicians alone. We also have training and education programs for paramedical staff. We run a diploma in oncology nursing and a diploma in critical care nursing and so on. And we have just commenced recruitment to the first bachelor's program in oncology nursing in Pakistan. And that's a 4-year degree program that we're running here at the hospital in association with a local university. We also have a number of education programs for allied health professionals. And of course, the last part of the mission statement with regard to education was education of the public. And so we run a number of cancer awareness programs. This is one of our award-winning, in fact, cancer awareness programs that we ran on World Tobacco Day, which we do each year, World No Tobacco Day, sorry. And each year, we've just finished, actually, throughout the month of October, we run a highly visible and widespread campaign to raise awareness about breast cancer. We've been doing this consistently for 25 years. Trying to stress the importance of early diagnosis and treatment for what is still the commonest cancer in Pakistan, the commonest cancer in Shaukat Khanum. And in fact, Pakistan has one of the highest incidences of breast cancer in females in Asia. So then we also have a commitment to perform research. We aim to always adhere to the highest scientific and ethical standards. We perform both basic science and clinical research. All research is run through our institutional review board to ensure ethical research is conducted and that the rights of the human subject are always protected. We also operate a cancer registry and a clinical data management unit. We operate and support the largest population-based cancer registry in Pakistan, which is called the Punjab Cancer Registry, which is run out of this hospital. Since inception, we have published over 550 peer-reviewed publications from our hospitals. And we are third in the period 2015 to 2019 amongst all Pakistani institutions in terms of publications in the medical literature. This is the structure of our research program here at Shaukat Khanum. I've talked about ethical review and I've talked about the cancer registry. The latest is that we also now have a tissue bank where we're storing samples from all the common tumors that we see, which will form the basis of future research projects for our own institution, as well as in collaboration with others, both nationally and internationally. We do have a number of highly qualified and trained professionals, both in clinical research, in basic sciences, biostatisticians and epidemiologists, trained research nurses and pharmacists, and of course, qualified and experienced physician investigators who have all been trained in good clinical practice. We have a dedicated basic science lab with state-of-the-art equipment and a biobank, as I said. In terms of the future, so all parameters of clinical activity have continued to grow from our inception in 1995 or at the end of 1994 all the way through to this year. Whether we look at diagnostics or admissions or treatment sessions, it's all gone up exponentially. And as a result, you've seen some of these images before. The image on the left shows the existing hospital to the right of that image and a new clinical tower, which will where we will start construction at the end of 2021, which will take, inshallah, about 2.5 years to complete and which will effectively double the capacity of the Lahore hospital where we are currently. The Peshawar hospital in the middle, phase 3, which was the final phase of development of this hospital, will be completed on the 1st of March 2021 when we start surgical services in Peshawar. And of course, the image on the right is the hospital in Karachi, where we've just started construction. So again, that's a larger view of the clinical tower. And that's the latest architect's rendering of the hospital in Karachi, where construction commenced in September 2020. As I said, this will be our biggest hospital to date. In the basement, we have our radiation facilities and nuclear medicine. On the ground floor, we have outpatients, the emergency room, some diagnostics, and the pharmacy and cafeteria. The first floor will be given over to chemotherapy, the pathology lab, a bone marrow transplant unit, and our endoscopy suite. The operating rooms will be on the second floor, as will the intensive care unit. And then there will be 3 floors of inpatient units with capacity for 400 beds when the hospital is completely functional. The facilities, as I said, the hospital will be twice the size of the Lahore hospital, and it's effectively all the services that we envisage that we feel we will provide there reflect that. Currently in Lahore, we have close to 200 beds, just as an example. Some famous visitors and supporters who've helped us in the past. And a generational divide, but some more recent visitors. In closing, I'd like to just thank, in particular, Sumaira Bhatt, the symposium chair, and Asad Pervez, the symposium co-chair. They had a very difficult task this year. This is our 19th symposium, and it's almost become a joke that we can organize a symposium reasonably well, we like to think. But this was an exceptionally difficult year to organize a symposium in, and they've really done a tremendous job and done us all proud with the way they've organized the symposium. It's been flawless, and we hope that you enjoy the talks and all the sessions. I'd also like to echo Sumaira in thanking Anika Agha and her colleagues in the medical education department, and our colleagues in IT, especially Hasib and Sana, and everyone else who's worked so hard to make this a success. I hope you enjoy the rest of the sessions, and the symposium as a whole. And I'd also like to thank, in closing, our colleagues from ASCO who have donated so generously of their time. And I believe it's probably still very early in the morning in the United States. So thank you again.
Thank you so much, Dr. Asim. So our next presenter is from ASCO, and I would like to invite Professor Frederick Smith. He's a board certified medical oncologist specializing in breast cancer at Sibley Memorial Hospital, and he's an instructor at Johns Hopkins School of Medicine. He has over 40 years experience in the field of oncology, and he has served as a director of extramural oncology research at Georgetown University, USA. Dr. Smith is well published and has contributed to over 70 oncology publications in peer-reviewed journals. And Dr. Smith is an integral advocate in the community for promoting access to clinical research and has contributed to the clinical trials. I invite Dr. Smith to share his presentations and talk about escalation and de-escalation in breast cancer patient, where resources are limited and how we can do it where there is evidence. Thank you so much, Dr. Frederick Smith. Over to
Thank you, Dr. Bhatt. I hope you can all hear me. Good morning and salam alaikum. I thank the organizers of this conference for inviting me and allowing me to be a party to the entire symposium and to present this particular topic. In special thanks to obviously Dr. Sumera Bhatt and Sarah Bachman of our ASCO for their indefatigable work in organizing speakers. So if I may, I will try to get my screen up and share with you my topic. So here I have my contact points, and Dr. Bhatt, I believe, is now a recipient of a copy of all my PowerPoints that is part of this talk. So the topic I chose was escalation, de-escalation of management of early breast cancer, and weaving through that how one might maneuver where there is financial and cost limitations. I've sort of divided up into three entities: the hormone receptor positive, HER2 negative, early breast cancer, and then subsequently the same entity with the use of chemotherapy, and finally the HER2 positive patients. So in the hormone receptor hormone adjuvant therapy, an escalation was the duration of treatment, where from 5 years, we learned that 10 years might be more effective from the early breast cancer trialist group with the ATLAS and ATOM. In addition, MA17 and SABP, big I93, among others, seem to imply the importance of an aromatase inhibitor along the way, and again, the duration. So to a certain extent, that represents escalation, but I think it's important to also scrutinize who merits such escalation. To be sure, these are individuals who would have more advanced disease at presentation, who might mandate chemotherapy. And how about de-escalation? Well, these are oral drugs. They're inexpensive. So perhaps one, other than for significant symptom protection, does not bother too much. In the US now, we're looking at prognostic and predictive values for extending beyond 5 years. In the premenopausal stage of disease, the soft and tech studies have suggested that ovarian ablation and hormonal adjuvant therapy might lead to better results. So that's escalation. However, scrutinizing the results would suggest once again that it is really, the benefit is really limited to the more advanced at presentation. And consequently, we might spare our patients the difficulty of hormone deprivation. Now, I'd like to show you recent data of adding cyclin kinase inhibitors in more advanced breast cancer. And there are 3 studies that were in progress. PALLAS, which used palbociclib, in addition to standard hormonal therapy. And that has read out as a negative study. But as I was educated by my colleagues at the first session, and once again, I remain impressed at how much on the cutting edge Dr. Siddiqui, Dr. Dawood, and Dr. Rashid, and all my medical oncology colleagues in Pakistan are. She elegantly pointed out that Dr. Dawood did, that the choice in the palbociclib study included much lesser stages of disease. Monarch E was abemaciclib, and I will show you that data, and that was selected for truly more advanced hormone receptor positive patients. The NATALEE is yet to be read out, and this is ribociclib, and we should see that forthcoming. So for the Monarch E then, the understanding for all of us is that hormone receptor positive breast cancer has a lingering risk, and up to 20 to 25% of our patients will still have metastatic recurrences well after 5 years, and that our present hormonal adjuvant therapy could and should be improved upon. So in this study, they took patients who were in a more advanced stage. Excuse me, let me return to that slide. And I'm sorry, I'm having some technical difficulty here. And the left box will show that, I'm going to see if I can turn my pointer on. The left box will show the selection of patients. Again, patients with greater than 4 positive nodes, or if they had 1 to 3 nodes, they had to have an additional criteria of a size of tumor greater than 5 centimeters, histologic grade, and they used the Ki-67 index of greater than 20%. There were 5,000 plus patients randomly allocated to the standard of care of hormones for 5 to 10 years, as was indicated. And in these patients, I would say that 10 years is probably a reasonable choice, or the same care with the addition of abemaciclib for 2 years, the primary objective being invasive disease-free survival. And there was at 2 years a distinct advantage in the disease-free, metastatic disease-free survival in the individuals receiving the abemaciclib addition to their hormonal adjuvant therapy. Now, this comes at a price. This particular cyclin kinase inhibitor is felt to be more bone marrow sparing and more diarrheogenic. And in fact, one has to be very aggressive about, from the get-go, proactively preventing this diarrhea, which can be profound. There is still marrow suppression with this drug, nonetheless. And the conclusion of this study presented at ESMO this year was that combining abemaciclib to a hormone adjuvant therapy showed a statistical improvement of up to a 3.5 absolute improvement at the 2-year point. And from our knowledge of hormone receptor positive disease, as has been shown from the very beginning with tamoxifen, that this advantage we would speculate might grow as the years go by. The diarrhea has to be managed proactively. And what was curious was that there was a reduction in the arthralgias and vasomotor side effects that hormone deprivation can cause. So to that point then, I think one would consider de-escalating. But if you're to escalate, I think you should critically look at these studies and look at the subset analyses and pick who merits such escalation. Now, in the use of adjuvant chemotherapy in the hormone receptor positive HER2 negative patients, As a result, as I will show you, of the NSABP B20 studies, all patients with a lesion greater than 1 centimeter, even node negative, were advised chemotherapy adjuvantly up till several years ago. The advent of genomic prognostication and, in fact, prediction with the OncoDX test has led to a change in that, and I'd like to review that briefly with you. I was told yesterday that OncoDX is available and used to do that discrimination in Pakistan. So this is the NSABP study, and unfortunately my screen blocks out some of my shared slide, but you can see that this difference of adding chemotherapy to tamoxifen has led to the universal use of chemotherapy in this situation. The Taylor RX exploited the more recent genomic analyses of prognosticating and predicting, and recognized by looking at the curve that there was a group that had an excellent prognosis and would very unlikely merit chemotherapy, a group that were at perhaps greater risk who should receive chemotherapy, but took this intermediate group of now 6,000 patients and randomly allocated them to the what was considered standard arm, where everyone was getting chemotherapy followed by adjuvant therapy, as opposed to just hormonal therapy alone. And Dr. Sperano presented this data some years back, and there was in that group no clear evidence of relapse-free or overall survival. A small caveat, though, is that in the premenopausal patients, in that intermediate group, between 20 and 25, perhaps a consideration should be given to adjuvant chemotherapy, or consider the soft data and be more aggressive in the hormonal manipulation. So that was a node negative disease. The companion study was with MammaPrint, which is a 70 gene analysis, and the MIND-ACT studies look at more advanced stages up to 3 positive nodes, and they have read out and was presented most recently that the value in the 1 to 3 positive nodes of genomically low risks, that there is perhaps minimal, if any, benefit. And I think that the RX Ponder, which reverts back to OncoDX analysis of looking at the 1 to 3 positive nodes in a lower recurrence score, should read out soon. And my educated speculation is that it'll mirror the Taylor RX study and show little advantage to chemotherapy in the genomically low recurrence score patients. So turning then to the HER2/neu positive disease state, and I'll take the liberty, in the interest of time, of just briefly describing the study. So neoadjuvant therapy for HER2/neu positive patients is now the state and standard of care, certainly in the US. And I was led to believe that was often the need and the practice by virtue of how relatively young patients that Dr. Shahina Dawood presented yesterday show up. So I'd like to remind us of the NEO-ALTO study, which used lapatinib, which is, in my view, at least a poorly rolled out drug, and in the US at least almost abandoned. But the NEO-ALTO study was a randomized study looking at dual adjuvant trastuzumab lapatinib in the neoadjuvant phase. And there was, and it's been now published, a small improvement with dual HER2 new blockade. However, the subsequent analysis of adding pertuzumab to trastuzumab in the Trifina and Neosphere, again, phase 2 studies, demonstrated up to an 80% pathologic complete remission rate in that group. And this is the Trifina study. And I'll just focus on this area where, with the use of dual therapy in the hormone receptor negative and the hormone receptor positive patients, there was substantial improvement in the pathologic complete remission rate, at least compared historically. And consequently, in the US at least, I would say that this has been adopted as the standard of neoadjuvant care. However, at the end of neoadjuvant therapy, there are still patients who are left with residual disease. So the Catherine study looked at those patients who would either go on with the standard of treatment of finishing a year of trastuzumab to the one-on-one randomization of TDM1, Kadcyla, versus the standard of care. So these patients were appropriately stratified for residual disease status and also disease status at the beginning of the study. This was the endpoint, a substantial 11% disease-free survival for those individuals on the trastuzumab, over the trastuzumab arm with the use of Kadcyla. The overall survival is yet to be shown to be statistically different. Now, that has led our American standard, I think, is to use neoadjuvant dual HER2 blockade with trastuzumab, pertuzumab, and then subsequently, upon completion of that, strongly consider Kadcyla. In the studies that were designed, this included individuals with hormone receptor positive disease who had tumor sizes greater than 2 centimeters, but might be clinically node negative. I'd like to show that before we go to that next step, the side effects and toxicities of TDM1 is to be expected. There is the payload of M-tansine chemotherapy, so there is cell count depression, but also neuropathy. So I've presented to you the neoadjuvant studies, and I'd like to point out that it is an axiom that if you achieve a pathologic complete remission with neoadjuvant therapy, they have better outcomes than those who don't receive a pathologic CR. However, if you look at the intent to treat in the entire group, there is not a clear-cut survival advantage of neoadjuvant therapy over non-neoadjuvant therapy. And I think one might consider that when we move towards considering de-escalation. So in the adjuvant therapies, in spite of neo-alto showing advantage of dual blockade, the ALTO and the NSABP study, which looked at adjuvant addition of lapatinib, there was no statistical significance. There was, in the ALTO study, perhaps a 1 to 2% advantage, but it did not achieve statistical significance and was interpreted as a negative study. The Affinity looked at adjuvant Herceptin Perjeta, and there the benefit was perhaps 2%, but largely in node positive disease. And it, again, I think reflects the fact that adjuvant treatment with dual therapy has a slight advantage, but perhaps one should consider which companion drug we use when there is need for cost containment. So the ATTEMPT study was reported December in ASCO in San Antonio by Dr. Taleni of Dana-Farber, a phase 2 look at TDM1 versus Herceptin paclitaxel, and it was a phase 2 randomized study, minimal advantage of TDM1, significant side effects, but more importantly, even in the US, what we call a financial toxicity. So I don't think that I would advise that as the consideration for adjuvant therapy at the present. The Caitlin study looked at adriamycin Cytoxan with dual trastuzumab, with Taxol Herceptin versus adriamycin Cytoxan with TDM1, and fails to show an advantage of that category. So then going on to considering extending therapy in HER2, the HERA looked at 2 years of trastuzumab adjuvant therapy and failed to show an advantage over a year. I'd like to present the extenet, and this was the look of adding neratinib, a tyrosine kinase inhibitor, which has been long in study, to standard completed adjuvant therapy with 1 year of trastuzumab. So these patients had completed their adjuvant study. They were then randomly, they would receive endocrine therapy if indicated, but upon completion of designed adjuvant year-long treatment, would be randomly allocated to receive either neratinib or a placebo. The primary endpoint was disease-free survival. So the results of the intent to treat population is a very modest 2.5% gain of adding neratinib to the conclusion of current standard of care. Interestingly, that, again, in trying to decide who one might consider the extended care, interestingly, it was more pronounced in the hormone receptor positive, and in fact may not benefit or even have a slight negative in the hormone receptor negative group of patients. And in looking at this forest plot, you'll see that there is really very little benefit in the node negative. The improvement is largely in node positive disease who are hormone receptor positive and not hormone receptor negative, which is counter to what we might speculate. I think the answer lies here, though. If one starts earlier with the neratinib addition, there is an advantage. If it's beyond a year, there is no advantage. And this is particularly true in the hormone receptor negative patients. So in escalating to extending HER2 adjuvant therapy, I think one would look again at the hormone receptor negative patients and perhaps add it in earlier after completion of a year of adjuvant therapy, particularly their multiple node positive. The side effect that's notorious for this drug, as for many tyrosine kinase inhibitors, is diarrhea. An aggressive early approach has to be taken and dose modification appropriately done. So the authors conclude that after 5 years of follow-up, extended neratinib adjuvant therapy did result in a 2.5% benefit, which in the hormone receptor positive cohort who were started on neratinib less than a year after conclusion of their traditional adjuvant therapy, that might go up to 5.1%. The diarrhea has to be aggressively managed. So in the de-escalation phase then, the APT study from Dana-Farber suggests that one can reduce the amount of chemotherapy given to just Taxol for 12 sessions along with Herceptin. So how would we de-escalate? So these, I've mentioned that the neoadjuvant is appropriate, certainly for more advanced disease. It's appropriate to consider in breast preservation cosmetic purposes, but in lesions that are less than 3 centimeters, certainly less than 2 centimeters, that are clinically node negative and that are hormone receptor positive, perhaps one should proceed with surgery first, then allowing us to consider de-escalating and hence cost containment. The ATTEMPT study was the Kadcyla, and that is reading out as likely negative. And then finally, the Persephone, FINHER, and a clinical trial from Italy would suggest that abbreviating the duration of trastuzumab may be as effective. As Dr. Dawood was quick to point out, this is not still the standard of care, certainly, but in a financially strapped situation. And in my own practice, if it's a hormone receptor positive, node negative patient, I will often offer a 6-month treatment. So finally, I feel I'm being a little bit presumptuous, particularly after Dr. Yusuf's very elegant presentation and description of the Shaukat Khanum, which I very much wish I could be physically present at, particularly after his presentation of the facilities. I was asked to talk about perhaps resource conservation and cost savings. And I'd like to just touch on a few subjects. Education, awareness, and early detection is paramount. And Dr. Asim Yusuf described the programs that you have, and they're certainly to be applauded, lauded, and expanded upon. I came across, but was unable to find the full article from Dr. Asif Farah in the Journal of Pakistan Medical Association of missing opportunity, which seemed to be talking about clinical trials, and I'll show you what my view is of that. I'm sure that you all do bulk purchasing of drugs. In our practices in the US, US Oncology, which we all know as a largest practice organization, partly sustains himself by the collective bargaining of cost reduction in purchasing drugs. So before talking about the other subjects, Dr. Yusuf has pointed out that Pakistan may have the highest incidence of breast cancer, that these are often presenting in advanced stages, leading to a higher death rate, and also in treating metastatic disease, we're using more resources, more drugs for a longer period of time, as opposed to if we can capture these patients earlier, hopefully we cure a greater number of these patients and use finite duration of therapies. So this addresses the missed opportunity of clinical trials. And again, I understand from the presentation by Dr. Yusuf that this is something being hotly pursued at the Shaukat Khanum. But I wanted to show you from my earlier presentation the 3 trials with the 3 drugs that have just become approved for these purposes in the US. And the first is in the HER2 CLIMB, which showed that the addition of the tyrosine kinase tucatinib to trastuzumab and capecitabine might lead to an advantage over trastuzumab and capecitabine alone. This is the representation of the participants, North American, Europe. We need that expanded. And in the trastuzumab deruxtecan clinical trial, it is a drug made by Daiichi, and consequently 34% of patients were Japanese, 37% European, and 28% North American. Now here to me is kind of the money slide. We need Pakistan more represented in these clinical trials. Among the missed opportunity is that often pharma will provide free drugs, including readily available drugs. If it's a phase 3 study, it offers us participation in cutting edge treatments with the intellectual stimulation that comes therefrom, and helping us to advance the field. And along with that, substantial financial support, which can be used to pursue our care of our patients. So the next topic then is to substitute biosimilars. And I just brought some examples out. Trastuzumab, per one treatment, costs us in practice $4,400. The biosimilar, about $1,000 less. The cytokine Neupogen, $1,300. The biosimilar, half the price. So I think this should be aggressively pursued. This has a little bit of my opinion in it, and I think one could consider substituting drugs, even though they may not be prime drugs. And Dr. Kamran Rashid pointed out that where Herceptin could not be used, he would sometimes consider lapatinib. And as I hope I showed you, it's still really a viable consideration. These are 3 tyrosine kinase inhibitors. I think from the NALA study that I presented earlier, which looked at neratinib, capecitabine versus lapatinib, capecitabine, neratinib is likely a better drug than lapatinib. However, there is advantage to lapatinib in this situation, where the cost of the drug, which now is generic and likely even less than here portrayed, is dwarfs almost that of neratinib and tucatinib. In the cyclin kinase inhibitors, we've seen this before, where there are 3 aromatase inhibitors and perhaps one that has a slight different mechanism of action than the other 2. I think that these extended hormonal adjuvant studies need to be scrutinized. Presently, abemaciclib has the lead, and palbo may not be as effective in that situation. But if collectively one drug is purchasable at a lesser price, maybe that's to be considered. And then finally, de-escalate. Our surgeons led the fray. They've gone from radical mastectomies to modified to now lumpectomies and sentinel node evaluations. I hope I've shown you that we medical oncologists have followed suit to a larger extent, and I hope that will lead to cost savings. Again, I thank the organizers for allowing me this time. I hope you will invite me next year when I can then visit the magnificent facilities that you have, and that landscape of mountains with snow capped is beautiful. Thank you very much. Goodbye.
Thank you so much. Thank you so much, Frederick. It was wonderful. It was an excellent presentation. You have been so kind to wake up so early in the morning and give us such an excellent presentation. We now move on to our second speaker, who's Mark Trombetta. Mark Trombetta is nationally and internationally known for his work in making radiation treatment easier, less toxic, and more effective for cancer patients. He's a long-time leader and radiation oncologist at Allegheny Health Network's Cancer Institute, USA. He currently serves as Assistant Director of Clinical Programs, Department of Oncology, and leads the department's breast cancer, cardiac radiation, and brachytherapy program. In addition, he is an accomplished researcher with over 70 publications. He has edited 2 textbooks and serves on the editorial board of 6 journals. Dr. Trombetta has also been appointed to numerous national committees, including Breast Committee and the local regional breast subcommittee of the NRG Oncology Group. I invite Dr. Trombetta to share his presentation on breast radiation, why less is better. Thank you, Dr. Mark.
This wonderful cancer symposium. I'm so
Thank you.
happy
We
to
have a
be able
good.
to speak at the request of my dear friend, Dr. Pervez Rahman, who asked me to speak at this symposium. I wish we could be present and together, but circumstances what they are, it's very difficult, as we know. But in any case, thank you for allowing me the opportunity to speak. And today I wanted to speak about the use of less and less in our field of radiation oncology. I'm a radiation oncologist in Pittsburgh, Pennsylvania, in the United States. And I wanted to talk to you about the evolution of things a little bit. Always I like to begin with a history lesson to refresh our minds about how far we've come and how far I think in the future, which we can't predict, but I'm sure it's going to be accelerating logarithmically. But anyway, so let's discuss the paradigm evolution when less treatment is better. Our field is moving tremendously toward less and less. And always, though, we keep in mind the goals of breast cancer therapy. They seem simple, they seem very evident, but it's probably a good idea to review them. So for the most emboldened bullet point there, it's cure the cancer. But in the realm of curing the cancer, and historically we'll see a few slides in the future that will talk about this, we also want to see if we can do things to improve convenience, to improve the patient experience. You have to think about the economic, not ever care. And with that, improving patient experience comes a look in the future as to whether or not we can do less things to people with same or even better outcomes. And we're doing that. We've gone to sentinel lymph node biopsies. We've tried to find ways where we can exempt elderly patients from radiation. We are trying to not treat with low-risk cancers such as ductal carcinoma in situ. And one of the things that in radiation we're doing is to try to give limited radiation, no radiation if would be possible, but certainly limited. Now, if we go back to the horrible time, but this was the standard of care for 75 years plus, when Dr. Halstead at Johns Hopkins advocated strongly for the radical mastectomy. And thank God this is no longer done, but it took a long time to change the paradigm of practice. And that started back in the 70s with a visionary Dr. Bernard Fisher. And Dr. Fisher is just passed away at over 100 years old. Was truly an icon and a local guy here in Pittsburgh. And he advocated for less surgery, moving forward with a modified radical mastectomy, which was not so much a debilitating procedure, but still left the patients without a breast and cosmetically unacceptable by today's standards. Although, as we know, mastectomy is still an important part of breast cancer care. Later on, in the 80s, 2 simultaneous studies came out and said, well, you don't have to do mastectomy, as we know. We can do lumpectomy, and you can see the small curvilinear surgical incision here in the breast, a tiny bit of tissue deficit. But overall, compared to what we saw before, huge change in things with the addition of whole breast radiotherapy. And concurrently, 2 studies came out, one from Milan and one from the NSABP, headquartered in Pittsburgh still. And they proved that with phase 3 data, without a doubt, that there was equivalence for early stage breast cancers with mastectomy. So it hugely changed the paradigm in care. But once again, it took a long time for the surgical community to catch on. Mastectomy rates in the United States didn't change uniformly for almost 8 to 10 years. But now, thankfully, they've changed significantly. So when we talk about doing less, we have to think about doing less in our own field of radiation oncology. And, there are problems that we can cause. And certainly if we could do one single treatment or no treatments, that's ideal for the patient. But we know that volume is a big problem for us. When I say volume, the larger the volume of normal tissue that we treat, the more side effects. So we see that in that risk area where we take a lumpectomy out and then remove the breast. And this is a very crude cartoon that really is, if you guess what it's going to look like after you put the seeds back together, it's not exactly the way it looks. But just to highlight that, perhaps if we look here at these little tiny potential cancer cells in the periphery, this is our target now. We know this, as we're going to see in a little bit, that sometimes you don't have to treat the entirety of the breast. You can focus on this. So we know, even long term, and then these have even been updated, that the difference between people that have had breast conserving surgery only and breast conserving surgery with radiation, the failure rates kind of plateau at 10 plus years. And of course, their age and other factor dependent. So in younger ladies, these failure rates are a little bit higher, and in older, they're a little bit lower. And that helps us to tailor therapies as well. But it's well established now, and this is with 15 and even 20-year data from these 2 large groups and others. But I know in the United States, we were always trained that we should be very careful about how we fractionate, how much radiation we give per day, to the point where we dropped the dose per fraction by 10% arbitrarily, and we relied on essentially one single paper to tell us that would improve cosmesis. So this ran patient treatments into 7 weeks sometimes, and sometimes even longer. Now, the Canadians, and you'll see others who had led the way, Europeans and Canadians had led the way. And we were kind of stubborn in America. We didn't quite believe it. But the Ontario Clinical Oncology Group published 10-year follow-up data. And this is, for us, I think, in America, the seminal paper, the 10-year data paper that changed things. So they compared 50 gray and 25 fractions to 42.5 and 16. Doesn't sound like it's a lot, but when you're a patient under treatment, and we know that sometimes this 25 was 30 or even more, but sometimes when you're under treatment, this is a big difference in quality of life. But we were always trained, we were terrified. I was terrified to change the paradigm of my treatment patterns, and always were evidence-based, but we resisted because we were afraid of what would happen cosmetically. So in this study, at the 10-year mark, the tumor recurrence rates, the ipsilateral breast tumor recurrence rates, were identical within the 2 cohorts. That was good news. We weren't so worried about that, but we were worried about the cosmesis and what happened to these ladies. And doggone it if it didn't turn out that the cosmetic function was exactly the same. So the grade 2 side effects acutely, not so bad. But when you get to grade 3 and certainly into 4, if we can reduce that or prevent that, certainly that's the goal. But there was a little bit of predictive benefit in the patient cohorts, the tumor sizes. And once again, we look at the tumor size. So the smaller tumors had better cosmesis because the tumor bed is smaller, perhaps, when it's resected, the lumpectomy cavity. But these were the determinant factors, and there was a little bit of a change with systemic chemotherapy, but it was noted. But I think most of the cosmetic change comes from surgery. That's well documented, but then from radiation after that. In the UK, two twin sister trials, the START A and B trials, have now reported 10-year plus data. And they found similarly with slightly different treatment regimens, but there were 4,451 patients, and they allowed boost therapy, and that means additional radiation to the tumor bed. And 50% had boost, so that's even a bit higher dose. In the START A trial, there were 3 regimens, and then the findings were that the ipsilateral breast tumor recurrence rate was the same. But there was a difference in cosmesis with the higher dose per fraction regimen. And then the START B trial was compared only 2 regimens. And this regimen of 40 gray and 15 fractions, so it takes 2 weeks off of treatment, delivers the same biologic effect and less cosmetic problem. And guess what? That worked out pretty well because the ipsilateral breast tumor rates were essentially the same. Overall survival was unchanged as well. The most important thing for us was what happened to these patients. Did the breast become a disaster? Because that's what we had been told, and the answer was no. And we were surprised by that. But I'll tell you, when personally I started to treat with hypofractionation, I was very nervous about it. And we treated very small busted ladies who would have predictably less side effect, and doggone if they didn't. And this regimen is much less toxic acutely, and the same chronic toxicity of fibrosis and induration and breast deformity the percentages are the same. They're very good. They're very high. The cosmetic effect when patients are self-rating is very good. They're very happy. So Royal College of Physicians, radiologists made a pretty clear statement. There's no indication for more than 15 fractions for standard radiation. Now, there's slightly a variation on that because very large busted women, we are unable to have hypofractionation because there's a discordance in the homogeneity of dose throughout the breast. So you have to be very careful when and there are metrics that we use that are very clear, of course, in their volumetric metrics that we try to keep in our institution. We followed what was a point dose prior, but between 105 and 107% hotspot, so to speak, in the breast. So that means a variation of +5 or +7% throughout a significant volume should not be allowed. And for very large breasted women, D-cup breast, and larger women, double D-cup breast, most of them cannot go through hypofractionation from breast size alone. But there are alternatives to that too, as we're gonna discuss. And then it takes you a little while to eat crow, and sometimes we'll publish a paper and make fun of ourselves. And in 2015, I put this into the journal Radiotherapy in Practice and kind of made fun that we were always talking about socialized medicine in other countries, and doggone if we weren't wrong. So you learn. And then we wonder now if this can be extended to women that have not had just lumpectomy, but have had post-mastectomy. And the answer is we think that's correct. Now, one of the problems that we have is the treatment of the other structures, the organs at risk, and the most at-risk structure because we know we're going to cause some fibrosis in the lung, no matter what the fractionation size is, because the lung is very sensitive. But the brachial plexus is a worry area. But if we go back to those START trials in those arms, there were 5,000 women, and about 25% of them had regional nodal irradiation, which included the axilla, which would include by default some or a good deal of the brachial plexus. In the 10 years, only one patient developed a plexopathy in the START A trial. None developed it in the B trial, and there were half the women were in the B trial. And cosmesis, local control, everything was identical to the larger regimens. So The Alliance group has now initiated about a year ago the RT-CHARM trial, which is kind of looking at this because the hypofractionation of lymph node irradiation has really not been studied in a phase 3 trial. But this group has decided to use post-mastectomy patients that require nodal irradiation, but also breast reconstruction. So there are many, many different endpoints here. Probably a smart way to economize on the trial. And these are for patients who are node positive N1 to 2A, M0 status. So T1 to T3 tumors can be included. And if the axilla has been dissected, there are modifications of dose to exempt that. But these are for patients with planned breast reconstruction, and it can be multiply done. So it's arm 1 is standard radiotherapy, 50 gray. We know that we've already shown hypofractionation to be effective, but this is looking at a bunch of different toxicity endpoints. So this is the same regimen that was done in the Ontario group in Canada, and they used a 42.56 gray, and that was the hypofractionated regimen that showed equivalence with cosmetic equivalence. And the modifier, and I'm glad they did this, was that the RT is only directed to the undissected axilla, so we're not overlapping and creating potential problems with hypofractionation in a dissected axilla. And the endpoints primarily would be to evaluate whether the reconstruction complication rate is non-inferior with hypofractionation. And the secondary objectives are almost as important. It's toxicity-based, of course, local and regional recurrence rates. And then they even did a very smart thing, I think, that they looked at the different opportunities for reconstruction, whether it's autologous tissue versus tissue expander and then following up implant, whether it's also immediate reconstruction or delayed. These will be very interesting. Based on the START trial, patients who had local regional radiation, seems that we'll not find toxicity, but of course that's not been studied directly in a phase 3 trial. This will be the first time. So these results, I think, are going to be extremely important. And that's what happens. You know, this is a grade 3 dermatitis on the right side, and on the left picture is how we traditionally do that. And if you look closely where these lasers are crossing, you can see these purple marks here represent a very large area. This is a fairly fair-skinned woman, which has a lot to do with it. It's a large busted woman. So she's a perfect setup for this type of problem. Treatment delays occur, potentially increases in local recurrence because of that. It's uncomfortable. Many times these patients developed telangiectasia in this area as a late consequence, sometimes significant inframammary fibrosis, which is a problem. So a number of years ago, a number of groups have studied whether or not we could make improvements on this by doing treatment to less than the entire breast, because patterns of failure were identified, and we noticed in some anecdotal studies that we didn't fail outside of the original tumor bed in many, many patients. So I think in Hungary, Csaba Polgár started to look at this and do interstitial radioactive implants in patients just to the areas where the tumors were. And those were some of the seminal early studies. And in America at the William Beaumont universities, the same question was being studied with external beam radiotherapy. We have long-term mature data from those institutional studies, and then some clinical trials otherwise have been reported on. In any case, we want to do it in a shorter time frame and reduce the volume, because we know we can treat very high doses. We've seen that in radiation in the brain and other areas, but we have to confine the volume down to small parts of the breast, because anything can be ablated, but we don't want to cause trouble. So once again, in Europe, the IMPORT-LOW trials started to look at partial breast radiation, which was somewhat like tangential radiation that we do if we go back to that picture there, where the entirety of the breast is treated with a kind of glancing tangent treatment. But the import low trial was treating less than the entire breast, once again with the intent to reduce volume. It used a hypofractionated regimen, and in one arm of it, they had a simultaneous boost, so they did radiation to one area with a higher dose to the local area directly around the tumor bed. And local regional recurrence rates were very, very low. So this supported, of course, the idea of partial breast irradiation. The failures, which have now been termed elsewhere failures, meaning outside of the 1 centimeter around the tumor cavity, have remained low and somewhere around 5% for select tumors that are very small. So here's our risk area. If we go back to that cartoon, it's this, and I'm not to scale here, but it's this 1 centimeter around the lumpectomy cavity. And now in the newer protocols, we exclude the 5 millimeters from the skin surface to try to improve some skin cosmesis, and that's where we stand. So the risk area, we know, in 95% of the time, is this 1 centimeter area for small tumors around the tumor bed, not the entirety of the breast. So we can not treat this. We have less pulmonary morbidity. We have less cardiac morbidity if this is a left-sided tumor, because the heart sits right here and this part gets irradiated. The patients can have a quicker treatment as well. So what happens? So how do we do this? How do we know? So a number of groups had studied this, and one way that was done externally was something we've been doing for a long time, but it was a 3-dimensional conformal radiation. So instead of, in this picture, which is a reconstructed image from a computer planning system, instead of treating this entirety of the breast, just straight across, we're treating from all these different angles and focusing on an area in the breast here, which you can see represented here. So this is the tumor bed with the gray fill. And then these are the risk areas, the clinical tumor volume, which is 1 centimeter around that, and then the planning tumor volume, which is our target. So it exempts all of this. And then when you think about it in 3 dimensions, it's a significant portion of the breast that's been exempted. So there have been many trials, some not so well done, like at the Christie Hospital early on, but some very well done, like the Hungarian trial that we talked about, where this was interstitial therapy, and the local regional control was equal. The cosmesis was felt to be better. And sometimes cosmesis is a subjective thing, but most of these trial groups not only rated it, at least more recently, with the physician, but some extended it to nurse and patients as well. Now, the target trial we're going to talk about a little bit later. There's some special concerns with that and factors with that. But you can see there are many, many trials. Now, in the one trial, the Ontario Rapid trial, which was the same as this is not a sister trial, but similar trial from the United States and other countries, the NSABP, there was a toxicity difference in cosmesis. In the Rapid trial, cosmesis was definitely worse. In the B39 trials, early reports were for worse cosmesis, but when the data were looked at and finally ironed out, the cosmesis was the same. So the toxicity was the same. And the B39 was the largest radiation trial ever done as a phase 3 trial. And did it help? Well, we're going to see that in a second. So this was the original discussion of the local regional recurrence for whole breast radiation versus partial breast in highly selected patients. This was an interstitial brachytherapy. The Hungarian trial was the original start of this, but then evolved into Jekestro. And then we saw the Rapid trial we talked about, which was a Canadian study, and this is the one with the poor cosmesis. And the local recurrence rates were about the same, but the cosmesis was a concern. So in the B39 trial, NSABP trial, this trial added lymph node positivity was allowed. So 1 to 3 lymph nodes were allowed if they were positive, followed by an axillary surgery. And it also allowed brachytherapy. So not just the interstitial brachytherapy, where the brachytherapy sources are placed into the tissue, but also with balloon brachytherapy, which many people may remember, and they're kind of like Foley catheters. They've fallen out of vogue in the United States now because of probably because of reimbursement codes, to be honest with you. But 29% of the patients were brachytherapy, 71% were external beam 3D conformal, and look at the local regional recurrence rates. But unfortunately, there was a 0.7% difference that was reported, meaning favored whole breast radiation. So even though this was a very large trial, they're statistically significant, and the New England Journal would not accept the paper because there was non-inferiority, but it was published in Lancet shortly after the New England Journal declined. So this is something to discuss with patients. And when we talk to patients, this 0.7% doesn't seem to bother not one of them. And they prefer the twice daily treatment for 1 week, which is what this trial was, as was RAPID, with good cosmesis, credible convenience, and local controls that are the same. So if we think about how they did that, then the next evolution is to consider even more focused, more precise, and shorter courses of treatment. We have precedence in this, and we've been doing stereotactic body radiation for a long time. And it's a high dose per fraction with minimal fractions, sometimes a single fraction. And we give a very potent biologic dose and a very sharp dose gradient, which you'll see in the future slide here, to once again highly impact the risk area, but minimally impact to the extent possible the at-risk, the non-at-risk area, the organs that are at risk that need to be protected. So the Florentine trial, which just reported its 10-year data in abstract form at San Antonio last year, and it's now in a full-length manuscript and peer-reviewed, kind of did that. They did 5-fraction treatment, every other day treatment. So it's a 1 treatment every other day for a week, 5 treatments. And they focused on the tumor bed. They published recently the 10-year follow-up. Now, this would be not exactly stereotactic because of the definitions, but as close as you can with traditional intensity modulation. And the patients were relatively favorable characteristics with small tumors. Margins of resection were at least 5 millimeters, and they always kept people above the age of 40 for eligibility. But in 520 patients, half and half of each group, and these were the randomization arms, they used clips in the breast, surgical clips. The B39 protocol used them originally, but they eliminated the requirement for clips because they migrate and you're clipping into fatty breast tissue. And you can imagine that once the fat necrosis because of the pressure on the clip just migrates. It kind of falls anywhere at once. So they're not the most reliable things, but there are some other things that we're thinking about now that can substitute. In any case, the overall survival, the disease-free survival, the local regional recurrence rate, same. And now, okay, what happens though? Because these are high dose, 600 centigrade, 1 treatment. And the cosmesis was better in the APBI group, in the short course treatment group. And so this is really something that's changing the paradigm. These data were just published full length a few months ago. So if we go back to that 3-dimensional conformal, because this is the same way IMRT is done, but the beams are modified differently internally, but they're still done from multiple beam angles focusing on the same area. We can compare that to the high dose rate brachytherapy, so you can see all these wires that are attached to the patient. This is another way to do focused treatment, because brachytherapy has always been considered the ultimate conformal therapy, because you're actually physically placing these catheters or however you whatever device you use right into or next to tumor regions. The target trial used intraoperative radiation. So there's a ball here and the stick, that's what they call it, the ball and the stick. And here's the device, goes into the breast, and it gives a very low 50 kV energy X-ray beam to the tumor bed, single treatment intraoperatively, probably the best thing that you could want, because the patient has the lumpectomy, has the radiation, and then this closed up, and that's it. And the data look really good. The data are in these graphs are 5 years, you can see, but they've been recently updated, and these data have held up. However, the trial was widely criticized, terribly in the literature, worse than I've ever seen, because they picked the best of the best patients, which is okay if you have a new trial and you're trying to prove something. But they left out some things like the fact that 20+% of patients had external beam radiation to the whole breast, and there were many, many problems. But at least what we're learning from this type of thing is that this focused treatment in a single fraction is a possibility. In Italy, they've been doing this for a long time with a different type of device. This is, as you can see, a much bigger machine. It was a little bit more awkward to use and a much more penetrating beam, because the problem with the target system is it doesn't penetrate very well. It doesn't cover that whole centimeter of depth. It's only a few millimeters. And the Elliott trial, they can cover this whole area here that you see in the dotted lines, at least in a few dimensions. Of course, it's not in a spherical dimension, and that's the advantage of the target device. But their recurrence rates also were low. Other researchers, this was pioneered by J.P. Pignol when he was at the University of Toronto, and he's been in Rotterdam, and now he's in Nova Scotia. And I know you're saying, what the heck are you talking about? The permanent breast seed implant, and here's a guy with a probe and a rectum, and this is the pubic symphysis, and these seeds are in the prostate. It's not a woman, and it's not a breast. But this is where this came from. So the idea that perhaps we could use permanent seeds, a one-time treatment, and be done. And in fact, that's what JP did, and he used ultrasound intraoperatively to place needles through the skin into the breast. And at the end of the day, the tumor bed, which you can see is here, and there's a little bit of fibrosis here, but in this particular patient, this was a surgical event already. This did not change significantly a complication, but then you'll see the seeds in the breast, and the local control for early stage invasive cancers for ductal carcinoma in situ, and now about 300 reported patients, is very, very low, and it's 1 to 2%. The mammographic identification of the tumor bed post-treatment has been acceptable. They've seen very well what can be seen, what can be not. On an MRI, you get, of course, a void around the metallic structure, but it does not compromise the ability to see if a recurrence is developing. And the patient goes home radioactive, but it's a very weak radioactive thing. They've done studies to show safety of this with family members. And here's the results. Of the worst results are sometimes a tiny bit of telangiectasia in the skin. Patients do extremely well with this, although you have to be technically very skilled to do this. It's not an easy procedure. Having done a few of them myself, I can tell you it's not easy. So it's not, the one negative is that to train docs to do this it's a lot of work for them, and not everybody's interested in that. So can we do something that we used to use many times on other areas of the body? Can we do something stereotactically? This is an older gamma knife, and it's a radiosurgical system for the brain. So it focuses on a small area. Sometimes it's been used all over the body, stereotactic body radiotherapy. In the lung, very frequently these days for very small patient tumors that are in patients who are ill, can't go through thoracotomy, have a poor pulmonary reserve, and even biopsies are risk. So can we do something like that in the breast? Well, we talked about the intraoperative radiation. It's a single treatment, yeah. But is there something that can be done that maybe eliminates the need for that device that you have to purchase, and the one that doesn't penetrate as well, or the big intraoperative device? Well, can we use the common things that we do now? Well, there's a machine called CyberKnife, which has been used extensively at University of Texas Southwestern in Dallas in the United States and other places. But the main thing is to give a very high intense dose in as short a time as possible, but protect the normal structures. So going back again to our seroma, our treatment risk area, the clinical target volume, which is about 1 centimeter, excluding the chest wall and the skin. And then a motion set up and dose build up and error. So when you look at the volume of this area being treated, in the B39 trial, the average seroma volume was 268 cc's, and in RAPID it was less. But these are large volumes. And small distances, as we know by the equation for volume of a sphere of 4/3 pi r cubed, that in small distances are going to make a huge difference in volume, and therefore huge differences in side effect. So if we would want something ideally that would look at stereotactic radiation where the dose 100% is given and a very sharp fall off occurs so that no other stuff gets treated, and then all the organs at risk are back this way as far to the y-axis as possible. So if you can separate between here and here, that's the best way possible to do it. We tried with balloons, and they give very high dose, but there's a lot of fall off dose that occurs to the remaining breast. So now what we're doing at Allegheny, we have a protocol in development where we're using with $1 million technological machines, a suture. A single suture that has a platinum core, and we use it as a fiducial. So we tie it in, and it's not exactly as it's showing in this cavity. We have now specified a 5 millimeter depth of implant of the suture, but it can conform exactly to the cavity all the way up in a spiral fashion and very precisely identify where we are and where we need to treat. And this is helpful for patients who have had oncoplastic surgeries. And because when the tissues are shifted, we don't know where they are radiation-wise, because many times the lumpectomy cavities are gone, and they're doing it to try to promote good long-term cosmesis, but we can't tell where the heck it was. So this wire, and it's a little difficult on this to see, but here it is here, but it's very easy to identify with a kilovoltage cone beam CT. It's called a Veriform suture. It's been out for a year or so, but it fulfills all the things that we need to think about when we are trying to target. There's another device. This is called a gamma pod. And I don't know if you can see the symbol up here in the upper right corner, but it's based on the principles of stereotactic radiation with a gamma knife. So these cones here, you can see are gamma sources, cobalt sources. And this cobalt source deck sits statically, but there's a collimation system that focuses the beam on a tumor bed in the center here. As you can see, these very dark areas represent the isodose lines. So when they are very sparse like this dose is very low. This dose is extremely high with a very sharp fall off, just like we wanted to see in this graph, a very sharp fall off that doesn't bleed into normal tissues. So we're about ready to start our gamma pod program at Allegheny. It's installed. There are 2 in the country that have been done. And these are the planning things. And so this is an easy to see one, but it's a very large tumor bed relatively. But you can see that the dose is extremely tight around the tumor bed, but protects organs, in this patient's being in the prone position, but protects the intrathoracic and intra-abdominal structures and even the contralateral breast. By delivering a very high dose rate. This is what it looks like. It's a formidable device. This woman is laid down on electronically on this table, and these doors open up and the sources are down in here, and they focus in on the breast. It's painless. Takes about 45 minutes, so it's a little bit cumbersome, but it does have the stereotactic potential. But that's what the device looks like normally, and to localize it, this is where a breast cup goes through and locks into the table. And this is the breast cup with the locking devices here. This fits on the skin with a vacuum seal, and the patient has an air pump that keeps the vacuum. and then keeps this in position for good immobilization. Now, better if we knew what we don't need to treat. And so now we're moving toward these genetic decision-making things. We know about Oncotype DX. We've been using it for a long time, but there was a subgroup that was identified and broken out of the SWOG 8814 study. And of course, this study had nothing to do with radiation. It was, you can see what the arms were. However, it was noted that in patients who had 1 to 3 nodes positive with an Oncotype score low, that the local regional recurrence without radiation was very low. When it was higher, the risk was significantly higher. Now that didn't translate out when it was greater than 3 nodes, but something happened here with 1 to 3 nodes. Something is telling us that the Oncotype may be able to be used to predict local recurrence and perhaps eliminate radiation in patients just based upon the risk scoring, similar to how we can eliminate patients from systemic chemotherapy. There's a trial out now looking at this. The MA39 trial is from the Canadian Cancer Treatment Group, and it's looking at not treating those patients that have oncotypes of 18 or less, and even node positives. So that trial is ongoing. There are no early data yet. It's just starting to accrue, and it'll be interesting. It's for both post-mastectomy patients and breast-conserving surgery. A newer, based on so this is a variation on a theme, the Decision RT assay, and you can see this is DCIS, is how it's spelled, and there are new trials ongoing for DCIS to see whether or not, and there's some early data in abstract format that show that we may be able to predict local recurrence based on this scoring system. Where it's going to end up, I don't know yet, but we'll see. We also know that similar to adjuvant online that was used many years ago, didn't require expensive testing, there's an IBTR online as well that does have predictive value. So there's a lot of tools, and it's an exciting time. And what we're trying to do is less, and it seems to be working. And I want to thank you for allowing me the opportunity once again to speak to you all.
Thank you so much, Professor Mark Trombetta. That was an excellent presentation. And now we'll move on to our next presenter. We have Professor Taufeeq Owonikoko with us. Thank you so much, Dr. Owonikoko, for joining us. I know it's very early in the morning for you, and you have been so kind to join us. And Dr. Owonikoko is a professor and vice chair for faculty development in the Department of Hematology and Medical Oncology at Emory University. He is also a Georgia Research Alliance Distinguished Cancer Scientist, and he has been on faculty at Emory University since 2008, and has focused his translational research activities on lung cancer, thyroid cancer, and early phase drug development. Dr. Owonikoko has received peer-reviewed grant funding from NIH, DOD, and Georgia Cancer Coalition. He has published over 219 reviewed manuscripts in high-impact journals, and he has done really exciting work in the field of thoracic oncology, and he has been kind enough to give us a talk on contemporary management of lung cancer update for 2020. Thank you so much, Professor Taufeeq.
Good afternoon. I'm Taufeeq Owonikoko, Professor and Vice Chair in the Department of Hematology and Medical Oncology, Winship Cancer Institute of Emory University in Atlanta, Georgia, USA. I'm honored to be part of this Shaukat Khanum Cancer Symposium, and I'm very grateful and thankful to the organizers for the invitation. Here are my disclosures, which should not affect the content or presentation of my talk. The outline for my discussion today is going to look at newly approved agents in molecular subset of non-small cell, look at agents with new efficacy data, even though they're not yet regulatorily approved. I will review some new treatment options available for small cell lung cancer patients. And finally, as we now focus our attention on smaller subset of non-small cell lung cancer, key considerations for optimal genomic profiling of patients. To get us going, I want to focus first on MET exon 14 mutation. MET is a commonly altered gene across various tumor types, and the mechanism of alteration can range from MET amplification to protein overexpression, and more recently, the newly discovered MET exon 14 skip mutation, which has been shown to be an oncogenic driver in about 3% of patients with non-small cell lung cancer. I also want to point your attention to the fact that MET exon 14 skip mutation is very heterogeneous. Therefore, the selection of the genomic testing platform is critical if these alterations will be reliably detected. Capmatinib is the first of MET-specific inhibitors to be approved for the treatment of this disease in a basket trial that enrolled stage 3B of 4 non-small cell lung cancer patients. Capmatinib was tested as a single agent, and various cohorts of patients were enrolled, including those with MET amplification defined by low or high gene copy number variation, MET exon 14 skip mutation, as well as treatment naive and previously treated patients. To your right is the result from different cohorts treated on this study. Specifically looking at patients with MET exon 14 mutation, capmatinib achieved an overall response rate of 41% in previously treated patients and 68% in treatment-naive patients. On the basis of this efficacy data, capmatinib was approved by the US FDA as a standard treatment option for patients with MET exon 14 non-small cell lung cancer. May I call your attention to the fact that patients with MET amplification did not seem to derive as much benefit from capmatinib compared to those with MET exon 14 mutation, and that informed the specific approval of this compound for those with MET exon 14 mutation. The agent was well tolerated. Peripheral edema was the most frequent toxicity, mostly grade 1 or 2, and this appeared to be a class effect. Upper GI toxicities such as nausea and vomiting were also reported, and occasional patients with pyrexia need to be recognized so that patient can be appropriately counseled. Tepotinib is the second MET-specific inhibitor to be approved for the treatment of MET exon 14 mutation. This agent was tested as part of a single-arm trial that enrolled patients using both tissue as well as liquid-based biopsy to identify patients with MET exon 14 mutation. Based on an overall response rate of 46%, which was comparable whether you identify patient by tissue or liquid biopsy or both, FDA granted approval for tepotinib to be used as standard treatment for MET exon 14 skip mutant non-small cell lung cancer. Progression-free survival was also comparable regardless of the mode of molecular detection, liquid, tissue, or both. PFS was comparable across the study. Adverse events with tepotinib also showed peripheral edema as the most common adverse event, and this was mostly grade 1 or 2 in 56% and grade 3 in 7% of patients. Upper GI discomfort was also present with nausea in 26%, and elevated liver enzymes was seen in a minority of patients, less than 10%. Tepotinib has now received FDA breakthrough therapy designation for MET exon 14 mutant non-small cell lung cancer. Switching gears to RET alteration. RET is a driver alteration originally described in patients with medullary thyroid cancer, but now known to be present in other tumor types. Alteration in RET can be in form of fusion partner genes or in non-synonymous point mutations in the RET gene itself. Prior attempt to use multi-kinase agent to target RET has been unsuccessful, and shown up here is a heat map showing the poor activity of many agents that were purported to be RET specific or RET targeted agent with very limited activity against RET. More importantly, all of these agents also had non-RET targeted activity that conferred additional toxicity in patients. Here is a summary slide of the most frequently encountered RET alterations in various tumor types. RET could be found in up to 1 to 2% of patients with non-small cell lung cancer, 10 to 20% of papillary thyroid cancer, and in patients with Mann-2 syndrome as the primary driver alteration, RET is found in 100% of patients. Shaukat is the first of the RET-specific inhibitors to be evaluated in RET-driven non-small cell lung cancer. In the LOXO 292 trial, libretto study, patients with non-small cell histology were enrolled, and I want to call your attention to the fact that RET alteration can be found in various subtypes of non-small cell lung cancer, ranging from adenocarcinoma, which is the majority of cases, but also squamous cell carcinoma, large cell, as well as not otherwise specified histologies. Shaukat displayed impressive results with very, very deep response and durable response, both in previously treated as well as previously untreated patients. Response was also seen in patients with fusion alteration as well as in those with point mutations. Shaukat is well tolerated, most frequent toxicities being diarrhea, dry mouth, and hypertension, and majority of these cases were mild grade 1 or 2 adverse events. Shaukat is now an approved agent by the US FDA as standard of care therapy for RET-altered non-small cell lung cancer. The second agent that's been tested for RET-altered non-small cell lung cancer is pralsetinib, or Blue 667. As part of the phase 1/2 ARROW study, that was a basket trial enrolling various tumor types, patients with RET fusion positive non-small cell lung cancer were enrolled. Pralsetinib showed an impressive response rate of 73% in treatment-naive RET fusion positive lung cancer and 61% overall response rate in previously treated patients. Switching gears to ALK. There are currently 5 approved agents for ALK-driven non-small cell lung cancer, both in the frontline as well as in the post-frontline setting. At this year's ESMO, we saw results of 2 head-to-head comparisons of 2 new agents for the frontline treatment of newly diagnosed anaplastic lymphoma kinase positive non-small cell lung cancer. EXALT 3 trial is a randomized study of encertinib versus crizotinib in ALK positive patients. And encertinib is a very potent next generation orally available ALK inhibitor. It showed very, very strong specificity for ALK, but also targets some additional genetic alterations that have been shown in preclinical testing to drive ALK resistance. It is more than 10-fold as potent as crizotinib in enzymatic assays. In early phase trials, encertinib was shown to have very promising anti-tumor activity in ALK inhibitor naive and pre-treated patients, which then informed the design of this trial. That was a global phase 3 trial that randomized newly diagnosed ALK positive patients to receive encertinib or crizotinib. Patients who had received not more than 1 prior line of chemotherapy were also allowed on trial. As you can see, stratification was by prior exposure to treatment, performance status, as well as presence or absence of brain metastasis at baseline, with the primary endpoint of blinded independent review committee assessed progression-free survival in the intention to treat population. Approximately 400 patients were screened in order to enroll 290 patients. At the end, blinded independent review assessed progression-free survival was in favor of encertinib with a median of 25.8 months for the experimental arm compared to 12.7 months for crizotinib. Hazard ratio of 0.51 that was highly significant statistically. The median progression-free survival data was mature enough with a median follow-up of more than 20 months on both arms. Duration of response was also very impressive, with the median not yet reached in the encertinib arm and about 27 months in patients who responded to crizotinib. Overall survival was immature, but was trending in favor of encertinib, with hazard ratio nominal of 0.88. At 24 months, equal number of patients were alive in the encertinib and crizotinib arms of the study at 78%. In terms of toxicity profile, encertinib showed greater toxicity with respect to skin rash, as well as liver enzyme abnormality. Majority of these adverse events were non-serious, and treatment-related AEs leading to dose reduction was seen about the same proportion of patients, maybe a little bit more in the encertinib at 24% and in crizotinib at 20%, leading to dose reduction, and treatment discontinuation in 9% and 7% respectively. In conclusion, the EXALT 3 trial showed that encertinib had very promising progression-free survival impact in this intention to treat population, with a 45% reduction in the risk of progression or death when compared to crizotinib. This superior efficacy was also noted in the brain over crizotinib, and the overall safety profile was tolerable, with low-grade rash and transaminitis as the most frequent. This agent is not yet approved, but based on the totality of this efficacy impact, it is very likely that this will be approved very soon as another option for frontline treatment of ALK-positive non-small cell lung cancer. Switching gears to another agent that was tested in the frontline, which is lorlatinib, which was compared to crizotinib, also in ALK-altered non-small cell lung cancer. This data was presented at this year's ESMO meeting, and it is the CROWN trial, a phase 3 study that compares lorlatinib to crizotinib as frontline therapy. And the rationale for this is the very, very promising efficacy of lorlatinib, especially with regards to intracranial disease in the post-frontline trial where it is currently approved. This observation suggested that lorlatinib may be better than currently available agents in preventing brain progression of disease, especially in this tumor type where brain involvement is very, very common. So the study randomized patients who have not been previously treated and with good performance status, allowing those with treated or untreated CNS metastases, as long as they're asymptomatic, to receive lorlatinib 100 milligrams once daily or crizotinib 250 milligrams twice daily. Primary endpoint of the trial was independently confirmed progression-free survival in a blinded fashion. The primary endpoint was impressive and met the pre-specified threshold, with lorlatinib achieving a median PFS that was not yet measurable, and crizotinib with a median PFS of 9.3 months. Hazard ratio of 0.28 and highly statistically significant. At 12 months, 78% of patients on lorlatinib were still progression-free, compared to only 39% of patients on crizotinib. Intracranial time to progression by blinded independent review also showed outstanding control of disease in the brain by lorlatinib compared to crizotinib. With hazard ratio of 0.07, lorlatinib was almost perfectly protective against disease progression in the brain compared to crizotinib. Looking at patients with both measurable or non-measurable disease in the brain, lorlatinib performed creditably well with intracranial response rate of 66% for lorlatinib versus 20% for crizotinib. And in those patients with measurable disease, the rate was 82% in favor of lorlatinib versus 23% for crizotinib. Median duration of response in the brain has not yet been reached for lorlatinib, and it's about 9 to 10 months for crizotinib. Switching gears to small cell lung cancer to highlight something that is new and that has immediate practice impact is lurbinectedin. This is a novel anti-cancer drug that is synthesized from marine-derived tetrahydroisoquinoline alkaloid. It's an analog of a DNA-damaging agent that is currently used in sarcoma called trabectedin. Lurbinectedin is purported to work by blocking transcription and inducing double DNA strand breaks, leading to apoptosis. In addition, modulation of the tumor microenvironment has been implicated as a potential mechanism, especially through the inhibition of immune suppressor tumor-associated type 2 macrophages. Lurbinectedin has been well studied in small cell lung cancer in the relapse setting, with 3 different clinical trials looking at lurbinectedin and doxorubicin as a combination, lurbinectedin and paclitaxel as a combination, and single agent lurbinectedin as monotherapy. The monotherapy arm of these exploratory studies was what drove the accelerated approval granted to lurbinectedin by the US FDA. This is an intravenously administered drug that is given as a 1-hour IV infusion every 3 weeks. RECIST-defined objective response rate with lurbinectedin in the relapse setting for patients previously treated with chemotherapy showed an overall response rate of 35%. When broken down by chemotherapy sensitivity, patients with platinum-insensitive disease with chemotherapy-free interval less than 90 days achieved an objective response rate of 22% versus 45% seen in those with chemosensitive relapse with chemotherapy-free interval of 90 days or greater. Efficacy of lurbinectedin as monotherapy was seen very early and very deep, both in platinum-sensitive and in platinum-resistant relapsed small cell lung cancer. The agent appeared very safe. Most frequent toxicities are hematologic, which are manageable, in form of anemia, leukopenia, and thrombocytopenia. And treatment-related adverse events of fatigue and febrile neutropenia were also of low grade and manageable. On the basis of the safety profile and the efficacy signals seen in the relapsed small cell lung cancer setting, FDA granted accelerated approval for the use of lurbinectedin in relapsed small cell lung cancer in July this year. Finally, as we've evolved in our treatment of lung cancer, where we now no longer just rely on histologic subtype, but molecular subtypes, I want to spend the last few minutes of my talk to emphasize some key important considerations when it comes to genomic profiling. We now have various molecularly defined subtypes of non-small cell lung cancer, starting with EGFR mutation through ALK, ROS1, KRAS, MET, RET, and TRK fusions. Indeed, there are now 7 different molecularly defined subtypes of non-small cell lung cancer for which we have approved standard of care therapy. This includes EGFR mutant, ALK altered, ROS1 positive, BRAF mutant, MET exon 14 mutant, RET altered, and TRK fusion positive variant of non-small cell lung cancer. HER2 altered as well as KRAS mutant disease also have investigational agent with very, very promising efficacy data where we expect regulatory approval in the coming years. Indeed, professional guideline recommendation these days would suggest that all patients with non-small cell lung cancer, regardless of histology, whether adenocarcinoma, large cell neuroendocrine, non-small cell not otherwise specified, or squamous cell carcinoma, should undergo molecular testing as part of their initial evaluation if they have advanced stage or metastatic disease. So what should we consider when we're thinking of genomically profiling our patient with newly diagnosed lung cancer? Who should we test? Are we safe using demographics or tumor histology? What should we test? What sample is important? Blood, tissue, and how do we collect it? Resected sample or core biopsies? Can we use body fluid that is not blood? And when and how should we test? Should we retest patients with early stage disease who later progress and suffer disease recurrence? And what is the best approach? Single gene testing versus next generation multiplex testing? And more importantly, as RNA-based testing are now becoming clinically viable, how should we choose between DNA and RNA-based testing strategies? I want to share this just to remind us how important it is for us to genomically profile our patients. This is a small study out of the US looking at publicly available data sets and comparing the overall survival in patients who underwent genomic testing versus those who did not, regardless of treatment. And this study is showing that those who had genomic profiling had a significantly better overall survival. But more importantly, the driver of this survival benefit appears to be those patients who had genomic profiling done and who then got appropriate targeted therapies. Indeed, the worst outcome was observed in patients who did not have any genomic testing done and had no record of systemic therapy. So it is very important that we test our patients, we test them early, and we test them appropriately. What should we test? The traditional approach has been to test tissue samples, but we now know that liquid-based biopsies are becoming more and more reliable and very comparable to tissue. So where we have limitation in terms of access to tissue or insufficient or poor quality tissue sample, we should not shy away from using liquid biopsy. To date, at least in the US, we have 2 blood-based testing that are now FDA cleared for testing to select options of treatment for patients with EGFR mutant lung cancer, as well as other mutation subtypes. And in this study, where they compare the outcome for patients tested with tissue or blood, we can see that majority of patients, you can still detect EGFR mutation and ALK, especially in tissue. But beyond that, by the time you start looking for rarer subtypes, such as BRAF, RET, MET, the proportion of patients being tested or being positive drops significantly. And this has to do perhaps with tumor exhaustion. When you compare cell-free DNA turnaround time to tissue, the turnaround time appears to be in favor of cell-free DNA testing. Importantly, when you use cell-free DNA, you are able to test the 8 guideline recommended biomarkers reliably, and comparative results, in fact, superior results may be obtained with cell-free DNA compared to tissue-based testing due to insufficient tissue sample. When should we test? As we've now recognized the benefit potentially of adjuvant targeted therapy, such as with the result of ADORA trial, as well as the CTONG trial, it is now likely that a significant proportion of our patients will be tested in the early stage setting. And the question is, when these patients later progress, if they were tested before and later recurred, should we retest them or should we rely on the original results of their genomic profiling? This is an interesting study from the MD Anderson Cancer Center group, where they looked at the distribution and prevalence of various genomic drivers in tissue samples from patients with early stage disease versus metastatic advanced stage disease. And what is obvious from this study was the fact that the prevalence for KRAS appeared comparable at 29% in both groups, but EGFR is twice as common when you look at metastatic disease compared to early stage. Importantly, about a quarter of patients tested in the early stage had no driver alterations, whereas in the advanced stage setting, less than 10% of those patients were found with no genomic driver. So what this study will suggest to us is that the incidence of specific markers that drive tumor growth could be different between early stage versus metastatic disease. In fact, it's possible that some of these mutations could be drivers of resistance or tumor progression, and therefore, for a patient previously profiled in the early stage setting, later suffering recurrence, it would be advisable to reprofile them. By chance, you might find a targetable alteration for which there are effective therapies. In addition, histology is no longer a reason not to test a patient. This is a study done in patients with squamous cell lung cancer, looking at cell-free DNA as well as tissue sample. And as can be seen here, various targetable alterations could be found even in patients with squamous histology, including EGFR mutation, MET exon 14 splice mutation, BRAF alterations, and ROS1 fusion as well as ALK. So histology is no longer a reason to test or not to test patients. It's more about the stage of the disease and whether or not we have access to appropriate treatment for whatever we find. Finally, the platform for genomic testing continues to evolve. We now have access to RNA sequencing, which can help identify rarer mutations, and especially when we are talking about fusions, which may not be easy to detect with DNA sequencing. At the current time, the use of immunohistochemistry or FISH to identify patients should not be part of our standard of care unless, for reasons of cost, if we cannot use DNA or RNA-based platform, then it is reasonable to use these other approaches rather than not do anything at all. This is an example of a study where transcriptomic analysis was able to identify additional alterations in patients who were primarily profiled using DNA sequencing platform. I'm using this to show us that when we have high clinical suspicion for a driver alteration and the DNA-based platform failed to identify a driver, we should consider the use of RNA-based platform if we have access, as you may be able to find additional alterations in about 25% of patients. And half of these will be alterations that you cannot detect using DNA-based platform. In summary, new agents targeting RET and MET exon 14 are now available, and they're now part of our standard of care treatment in 2020. Capmatinib and tepotinib are orally active and tolerable in MET exon 14 patients. Selpercatinib and pralsetinib both showed very impressive clinical activity in RET-altered non-small cell lung cancer. And ensortinib and lorlatinib are newer ALK-targeted agents with impressive intracranial and extracranial efficacy. The recently reported data for these agents are very encouraging and will support regulatory approval in the not too distant future. Finally, given the increasing number of targeted agents and molecular subset of non-small cell, next-gen sequencing platform should be the optimal tool to use in order to identify molecular subsets of lung cancer. And with that, I thank you for listening.
Thank you so much, Professor Amanokoko. Now, I would like to thank all the plenary speakers for their excellent talk. And we have few questions, but I think in the interest of time, we will email these questions to the speakers. And thank you again. Thank you once again. And we will close this plenary session. Thank you, Sarah. Thank you, Frederick Smith, for staying with us and giving us excellent presentations. And we all look forward to see you again tomorrow for the third day of symposium. Hope to see you again. Thank you so much.